quickly to my next presentation, which is hypersensitivity pneumonitis. So it used to be called extrinsic as allergic alveolitis, and it's simply a diffuse granulomatous inflammation of the lung parenchyma and airways in people who have been sensitized. So just think about it this way. So you have patients who are working in areas that have high exposures to antigens, allergies, like maybe I forgot to put those examples, but malt workers, people who work in haze, in bed fanciers lungs, so people who work like with chickens, haze, and just things that cause continuous persistent exposure to allergens, dairies, dots, proteins, reservoirs, just things like this that will keep causing aerosols and inhalations. These are people who have these hypersensitivity pneumonitis. So in by way of knowing it very well, you just have to know that there are three forms that it can come in. It can come in an acute form, a subacute form, or in a chronic form. So I just put this table to kind of differentiate it as per symptom and how they present. So an acute just means, okay, very rapid symptom. So they can have the flu-like symptoms, malaise, headache, and things like that. Just general feeling of unwell for the symptoms. But when it gets to the subacute, it's actually a very longer period. So they don't actually present with as much of a symptom as per the acute phase. So their symptoms are not as severe as the acute phase, because it takes a longer time before their symptoms will come up, and it's usually due to repeated acute attacks. But then the chronic, just remember chronic this way. Chronic is that the damage has already been done. So they've been exposed to this thing for a prolonged period of time. There has been repeated inflammatory processes going on in the lungs. Have been damaged, has referred back to the heart too is suffering. So they come with by the time it's chronic, there's nothing you can do. It will just progress to maybe the death of the patient. And because patient starts getting very breathless, the lungs have been damaged and stuff, so they can have very serious presentation. So acutely they will just present with sometimes they could be fine, but then they will have some crackles in the chest, but they rarely present wheezing. So they won't come in as though it cannot be fixed. It's usually something very rapid and always goes back very suddenly. The chronic can just come like a recurrent pneumonia. Might not really pick up so much, but by the time the subacute, but by the time they are chronic, sometimes you can pick up, obviously cyanosis, clubbing has set in, because this patient the lungs have turned to fibrosis, and fibrosis is a cause of finger clubbing. So by the time they are coming in, they are hypoxemic, there could be pulmonary hypertension, there can be right heart failure by the time it's chronic. And in terms of their symptom course, for the acute, they would usually start 4 to 8 hours. They can just resolve quickly, usually within 1 to 2 days, and it's just really flu-like illness. Subacute is after the exposure. If you remove the exposure, so whatever it is, so for instance, you ask the patient, I have identified the cause of your problem, which is the fact that you're working with birds. Would it be okay to find another job, or would you now use things to protect yourself, your nose and your mouth, from inhaling these substances? And the patient says, yes, I would like to do that, and they take precautions to preventing it. Then there might be some resolution of the symptoms after some weeks or months for the subacute. The chronic, even if you do everything you want to do, take all the precautions in this life, the damage has already been done. So there might just be a very minute symptom relief, but it will not change the course of the problem that has already happened. And in terms of chest X-ray findings, in the acute might just be normal stuff, and then the subacute will have like a micro, nodular, or reticular opacities at the mid and upper lungs. And then by the time it's chronic, obviously you'd notice fibrosis, and then a reduction in loss in the volume of the lungs. And how do you investigate it? So they could have raised inflammatory markers, some specific IgG antibodies. You can do a CT pulmonary. It's actually just going to show you what stage of affectation of the lungs. It's not, there is no like a definitive diagnostic investigation or treatment here. By the time you've gotten to chronicity, it's just going to show you how far damaged the lungs has gotten. If you do a lung function test in terms of spirometry to show you a restrictive pattern, and sometimes you can do the inhaled challenge test, just because you're trying to find out at this point what exactly could be the cause of this symptom in this patient. But it's always done in a specialized center, because if you are exposing the patient to the allergen, the supposed allergen, so you should be ready with the equipment and everything, manpower to resuscitate these patients in terms of any quick compromise of their respiratory system. And there's some other tests about bronchoalveolar lavage, where they can take a bit of a lavage and just check for lymphocyte count and things, just to support the diagnosis of some hypersensitivity going on. In terms of their management, it's basically symptomatic. The bulk of the management will be the avoidance of the exposure, but that also, like I said, will depend on the severity of damage already. They can use corticosteroid, but they also say that it does not alter the long-term outcome. So if the patient's lungs have already been compromised, it's just symptomatic relief, but will not change the course. And then other things that have been tried is the azathioprine and mycophenolate mofetil if they are resistant cases.